Okay, so this lecture we're going to examine several different drug classes that are kind of lumped together called GI drugs. And so basically we're going to cover heartburn to poop. Here's our learning objectives. What I've done, this is a little bit maybe a longer lecture. I've made orange, I think they're orange boxes throughout the lecture. So it says LO and a number. That signifies where the learning objective is satisfied. So hopefully it'll be easy to find um, the answers to some of these learning objective questions. Excuse me. So I basically divided the lecture into two parts. Basically, the first part is drugs that can control gastric acid. And basically we're going to look at the H2 blockers, the proton pump inhibitors, antimuscarinic drugs, and some of the cytoprotective agents. These are all kind of mechanistically will control gastric acid. And then on the other side of the diagram are basically all the other drugs. And so antibiotics for ulcer control, laxatives, antacids, prokinetic agents. So laxatives, if you have trouble going, prokinetic agents to kind of speed things along, and if you can't stop going, antidiarrheal agents. So we're going to cover all of our bases. So let's look at drugs for the control of gastric acid first and foremost. And we're going to have to spend a little bit of time looking at histamine. And so remember, histamine is basically converted from histidine, okay? And this occurs basically in different immune cells, so mast cells, basophils, eosinophils. And there are other tissues that can convert histidine into histamine. And remember, histamine is basically a neurotransmitter. Okay, and there's different receptors for histamine. So we've got H1, H2 receptor, and the expression profile varies. And so there's histamine receptors within the vasculature. There are histamine receptors within the cardiac system. There's histamine receptors in the GI system, lung, as well as skin. And so mechanistically, what we're looking at is when these receptors signal, histamine binds to the receptor, H1 or H2, and that's going to cause an increase in the amount of calcium within the cell, and that's going to increase the amount of cyclic AMP activity, which will thereby activate the proton potassium ATPase, and then that's going to pump protons, or hydrogen ions, into the lumen. Okay, so this is learning objective 1. Okay, and here's a good example. Here's the parietal cell, which makes histamine, and here's this mechanism graphically depicted. Okay, and so again, when histamine is being produced, when histamine binds to its receptor, we basically get a production of protons. And so this actually is going to cause a reduction in the pH, making the pH more acidic, less basic. And that's going to be basically the bane of our problem is really too much stomach acid within the GI compartment. And that's going to be kind of where we're going to start. Okay, so the first group of drugs are the histamine antagonists, specifically the H2 receptor blockers, and these all have the suffix tidine after them. And it may sound foreign, but if you look at the trade names, you've probably taken them, and I'm sure you recognize them. And so we want to antagonize that H2 receptor because we're going to treat heartburn as a result of gastroesophageal reflux disease, or GERD. Okay, and so what we do is we block that H2 receptor, which was shown on those parietal cells in the previous slide, and we're going to reduce stomach acid production. We're going to reduce the amount of protons being pumped into the stomach, which is going to be the cause of all that stomach acidity. We'll use it to treat gastric and duodenal ulcers. We'll also can use these drugs for a specific Zollinger-Ellison syndrome. And the clinical correlation here is we're going to kind of segue into H. pylori infections. And so the drugs that we're going to be talking about include ranitidine, which is the generic name for the trade name Zantac, cimetidine, which is Tagamet, famotidine, which is Pepcid, and then nizatidine, which is Axid. And I'm sure probably you've all taken these drugs at some point in your life, and you may even know people who need them quite often. These drugs are over the counter. They're quite safe, but there are prescription formulations that are still housed in pharmacies at much higher doses than you would give over the counter, of course. And so these H2 blockers, we said, effectively we're treating GERD, peptic ulcer disease, heartburn, and the prevention of bleeding from either stress-induced or drug-induced gastritis. And so typically these drugs will work for about 6 to 12 hours after that initial dose. Okay. Cimetidine in particular is well known for drug-drug interactions. It's got numerous CYP enzymes that are responsible for the biotransformation of this drug. Those enzymes are listed here. We can also see hormonal changes with cimetidine. It's been known, or it's been demonstrated, that it can inhibit the binding of dihydrotestosterone to some of those androgen receptors, and it also inhibits the metabolism of estradiol, and it may increase prolactin levels. So this would be problematic for patients who are, persistently take cimetidine daily for long-standing GERD or peptic ulcer or any of the other conditions that are listed up here. Patients that take cimetidine, once or twice a month, you wouldn't have to worry about these drastic hormonal changes. Along those same lines, ranitidine, a little bit better in terms of some pharmacological management strategies because there are fewer drug-drug interactions, which is always good. The side effect profile to any of these H2 blockers include fatigue, diarrhea, headache, constipation, but these, the incidence of these side effects are relatively rare and few and far in between. All in all, they're really more or less well tolerated. Patients that are getting hospital IV administrations of some of these drugs can see mental status changes. Remember, there's some histamine receptor subtypes within the brain in the CNS. And there's also a histamine receptor within the pulmonary circuit. And so some of those patients can see an increased risk of nosocomial pneumonia, so hospital-acquired pneumonia. The other group of drugs that you should consider are the proton pump inhibitors. These are the azoles. And so these are different chemically than like fluconazole and some of those other antifungal agents. These have a different mechanism of action, but they share a common medicinal chemistry type backbone. And so proton pump inhibitors, or PPIs, they produce real dramatic reductions in gastric acid secretion because they really strongly inhibit that potassium proton ATPase. And so in some cases, these drugs like Prilosec and Prevacid and Nexium, which are listed here, these drugs are actually superior to the aforementioned H2 antagonists for treating something like an NSAID-induced ulcer. One of the things that we haven't talked about is NSAIDs in particular, so ibuprofen, aspirin, and some of these other drugs that are COX-1 and 2 inhibitors. They have a very high incidence when given over the long term to produce a GI type ulcers, and these are a group of drugs that can actually be used to treat that. All these drugs are administered as prodrugs, and it takes a few days for them to reach maximal effectiveness. And so what happens is that these prodrugs are not biologically active. They rely on CYP enzyme biotransformation to activate them, and then it takes a little bit of time, a few days, to reach therapeutic serum levels. Okay, and so you've probably heard of these drugs too. These drugs are also now over the counter. Nexium is esomeprazole, Protonix is pantoprazole, Prilosec is probably the oldest in the category, omeprazole, and then Prevacid is lansoprazole. Asifex is it's been on the market, but it's not as common as some of the others that are listed there. The side effect profile is relatively benign. There's very few side effects: diarrhea, stomach pain, abdominal pain. Some patients report headaches, and then of course there's some potential interference with with minerals or certain foods and vitamins being absorbed. Remember, you're dramatically reducing the amount of stomach acid that's being produced in that compartment, and that's going to have a possibly deleterious effect on whether or not food or fat-soluble vitamins can be absorbed. We do see long-term effects, and you should be aware of this, and so you're going to see reduced calcium absorption. So patients, there was a clinical study that was reported a couple of years ago, patients that were on really long-term proton pump inhibitors had a much higher incidence of hip fractures, and they think which is basically due to long-term reduced calcium absorption. And so you have to kind of be aware, patients that have osteoporosis, patients that have low magnesium, they might need a little bit of some monitoring and possibly even a different drug class. When patients go off of these drugs, you can sometimes see rebound gastric acid secretion after they abruptly withdraw the drug for whatever reason after long-term use. And then for patients that have underlying cardiovascular diseases, there's a well-known drug interaction with these proton pump inhibitors and the agent clopidogrel. And so the pharmacodynamic interaction there basically says that the effectiveness or the biological activity of clopidogrel is dramatically reduced when co-administered with a proton pump inhibitor. And so then less clopidogrel activity favors more incidences of adverse cardiac effects. Okay, and of course the asterisk here basically details that these drugs are over the counter and then quite safe. So which are better? We talked about H2 blockers versus proton pump inhibitors. Which one would be better clinically? Well, there's a few things to consider. So H2 blockers, we said, reduce acid secretion. The onset of their activity is usually less than an hour, and the duration of their activity, in terms of reduced acid secretion, persists for less than 12 hours. Okay. Proton pump inhibitors can actually block almost all acid secretion. Okay. So this is, 80% of the potential stomach acid that's being produced can be potentially blocked by these proton pump inhibitors. However, the onset is several days. I'm sorry, several hours, but the duration of therapy is several days. Okay, and so clinically we can use both of these for GERD, we can use them for peptic ulcer and heartburn, but proton pump inhibitors tend to be more effective at changing the microenvironment of the ulcer that's associated with these H. pylori infections. Okay, so I like this chart because this was taken from a clinical trial, and what they did is they looked at the red as the baseline amount of stomach acid, and of course, the amount of stomach acid goes up every time there's a meal. Okay, so here's baseline stomach acid at this red line. I hope nobody's colorblind, but if not, you can see this first line right here. This is the baseline. This is the amount of stomach acid that's found in the individual. When the patient is placed on an H2 blocker, this second line right here denotes the amount of stomach acid that's found when the H2 blocker is on board. So you see a reduction, definitely. You definitely see a reduction in the amount of stomach acid, but it's still high. Okay, this is in contrast to this green line, which is way at the bottom. Okay, and so the only time you see an increase in stomach acid when a patient's on a PPI is basically towards the end of the day after a light snack. And so there's 75 to 80, 95% dramatic reduction in stomach acid production when a patient's on a PPI. Okay.